or have other cases to discuss, I'm here anytime.
Okay, today our subject is I need I need help regarding one baby 5 years old come with sudden pallor and jaundice.
Of course, I'm right here to help. We've already talked about the main differentials like hemolytic anemias, autoimmune causes, and hereditary spherocytosis. If you want, we can walk through a
What
step by
if
step assessment or
I will put five differential diagnosis, main five differential diagnosis for this case.
absolutely. Here are 5 key differentials you should consider. First, G6PD deficiency. Second, autoimmune hemolytic anemia. Third, hereditary spherocytosis. Fourth, acute viral hepatitis. And fifth, malaria, especially if there's a fever or travel history. Once you have your labs, you can narrow it down further.
Okay, so first I will put G6PD. Okay, it's very important.
Yes, that's a solid plan. Start with G6PD as your top suspicion, especially if there's a trigger like a recent infection or a known.
What is the clue for G6PD?
The key clue for G6PD deficiency is a sudden onset of hemolysis triggered by something like an infection, certain medications like sulfa drugs, or foods like fava beans. Also, it's more common in some males since it's X-linked, and you'll often see dark urine and mite cells on the blood film.
There is dark baby is pale, jaundice, dark urine, fatigue. Sometimes give family history, okay, and sometimes give drug history, and sometimes give history of fava bean. Yes.
Exactly. Those are all classic clues. So when you see jaundice, dark urine, and fatigue, plus a family history or a known trigger, that really points toward G6PD deficiency. Once you
Uh,
confirm it with the enzyme test, you'll have your diagnosis.
okay. What if I do blood film? What I will see in G6PD?
In a blood film for G6PD deficiency, you'll often see bite cells. These are red cells that look like they've had bites taken out of
White
them,
cells.
and
Yes.
Heinz bodies, which are small inclusions inside
Heinz
the cell.
body. Okay. Thank you.
You're very welcome. I'm glad that was helpful. If anything else comes up or you need to go deeper on any step, just let me know.
Yes. Okay. Uh, what
Great.
about NG6BD? I will send for hemoglobin, retic, bilirubin, total direct, LDH, haptoglobulin.
Yes, exactly. Once you get those labs, hemoglobin, reticulocyte count, total indirect bilirubin, LDH, and haptoglobin, you'll have a clearer picture. In
Okay.
G6PD, you'd expect a low hemoglobin, high reticulocytes, elevated indirect bilirubin, high LDH, and
Okay.
low
What is
haptoglobin.
the second differential diagnosis?
The second differential would be autoimmune hemolytic anemia. In that case, you'd look for a positive direct Coombs test, spherocytes on the blood film, and often a recent viral illness. So that would be your next step if G6PD tests come back normal.
What is the clue for autoimmune hemolytic anemia?
The key clue for autoimmune hemolytic anemia is a positive direct Coombs test, along with spherocytes on the blood film and a recent viral infection or other autoimmune symptoms.
Ah,
The anemia can
so there is recent viral infection and direct comp test is positive. With in blood film there is spherocyte with high reticulocyte. Yes.
exactly. That's a classic picture of autoimmune hemolytic anemia. So once you see those findings, recent viral illness, a positive Coombs test, spherocytes, and a high retic count, you can confidently diagnose AIHA and start.
There is splenomegaly or not?
Yes, exactly. In autoimmune hemolytic anemia, you'll often see a rise in direct conjugated bilirubin since the liver is processing the breakdown products of red cells. So that's a big
Hmm.
clue pointing toward hemolysis from
How
immune
can we
suppression.
differentiate between G6PD and autoimmune hemolytic anemia?
Great question. So the main differentiator is the direct Coombs test. In G6PD deficiency, the Coombs test is negative,
Ah,
while in autoimmune hemolytic anemia, it's positive. Also, G6PD typically follows a trigger like an infection or drug, and you'll see bite cells on the smear. In
okay.
AIHA, it's more insidious, often linked to recent viral illness, and you see spherocytes. So the Coombs test is really the key differentiator.
Ah, so comp test is very key and for help in the diagnosis of autoimmune hemolytic anemia. Okay. Third, differential diagnosis hereditary spherocytosis. Yes.
Exactly. So hereditary spherocytosis would be your third. It often shows up with a family history of jaundice, chronic mild anemia, splenomegaly, and on the blood film you see spherocytes. The osmotic fragility test or EMA binding test would help confirm it.
Could you
Once
repeat the clue for hereditary spherocytosis?
Of course, the key clue for hereditary spherocytosis is a family history of jaundice or anemia, along with chronic mild jaundice, splenomegaly, and on the blood film you see spherocytes, small round red cells. The diagnosis is confirmed with tests like osmotic fragility or EMA binding, and the inheritance
So
is
the
usually
test
autosomal.
is osmotic fragility and EMA binding, right? Yes.
Yes, exactly. Both the osmotic fragility test and the EMA binding test are key. The osmotic fragility test measures how easily the red cells rupture in a dilute solution, and the EMA binding test is even more specific. If it's abnormal, it strongly supports hereditary spherocytosis.
Okay. What is another differential diagnosis?
Another important differential is acute viral hepatitis. It can present with jaundice and sometimes pallor if there's associated anemia. You'd see very elevated liver enzymes, ALT and AST, and it's often preceded by a viral illness. So if liver function tests are really high, that might be your culprit.
Okay. What is other any
Another one,
other differential?
of course, another differential would be malaria, especially if the child is from or has traveled to an endemic area. Malaria can cause fever, anemia, and jaundice, and you might see red cell parasites on the blood smear. So
Okay.
rapid malaria tests would help rule that out too.
So I will add for malaria thick and thin blood film and malaria serology.
Yes, exactly. That's a great plan. Adding a malaria rapid antigen test and examining the blood film for parasites along with serology will help you catch any missed cases of malaria.
Okay.
Once you have those results, it should give you a clearer picture.
What about hemolytic uremic syndrome or microangiopathic hemolytic anemia? I will put in differential diagnosis.
Yes, definitely. Hemolytic uremic syndrome or microangiopathic hemolytic anemia should be in the differential. It often presents with a triad of hemolytic anemia, thrombocytopenia, and renal dysfunction. So look for signs like acute kidney injury, low platelets, and schistocytes on the blood film. That would help distinguish it from the other causes.
So the schistocyte in blood film.
Exactly. In microangiopathic hemolytic anemia, you'll see schistocytes on the blood film, those fragmented red cells. Plus, you'd see a high LDH, low haptoglobin, and often kidney involvement. So definitely keep that in the mind if the renal function is off.
Okay. So in this case, in first line test for this case, I will do CBC, retic count, peripheral smear, total and direct bilirubin, LDH, haptoglobulin, direct comp test, LFT, urine analysis, and specific test.
Yes, that's perfect. Those are all the essential first line tests. The CBC, reticulocyte count, and peripheral smear will assess hemolysis. The bilirubin, LDH, haptoglobin will confirm breakdown. The direct Coombs test will differentiate AIHA. LFTs will check liver function, and your analysis will catch any kidney involvement. Once you have all that, you'll be able to narrow down the diagnosis.
Okay.
Great. If you run those tests and need help interpreting them, or if you have any
If
other
I
questions,
found, if I find,
sure. If you find anything specific in the labs, for example, a positive Coombs test,
yes,
schistocytes, or
yes,
high.
yes, yes, you remind me. If I find positive comp test, how can I treat?
Ah, good point. If you find a positive Coombs test, that strongly suggests autoimmune hemolytic anemia. In that case, you'd start treatment with corticosteroids, usually prednisolone, and monitor the patient closely. If it's severe or not responding, you might add IVIG or consider further immunosuppression.
Uh, I
So
will
the
add
key is
IBIE or immunosuppression. Okay.
you're all set then. So if the Coombs test is positive, start with steroids, and if needed, add IVIG or other immunosuppression if the patient doesn't respond.
What
Let me
about
know if any.
if EMA positive or osmotic fragility positive? How can I treat?
Good question. If the EMA binding or osmotic fragility test is positive, confirming hereditary spherocytosis, then the mainstay is supportive care. If the anemia is severe, you might need transfusions. Over time, if they have recurrent severe symptoms, you consider a splenectomy, usually after age 5, since the spleen is the main site of red cell destruction.
Okay. What if I find G6PD is low?
If you find that the G6PD
How
level
can I
is low,
treat?
right. So if G6PD is low, the management is mostly supportive. You want to avoid any triggers like certain medications, fava beans, or infections, and provide supportive care. If the anemia is severe, you might need a blood transfusion. But once the trigger is gone, kids often recover well.
What if hemoglobin is low, 7? I will transfuse blood.
Yes, exactly. If the hemoglobin drops below 7 grams per deciliter, or if the child is showing signs of poor perfusion, fatigue, or other instability, then yes, you should proceed with the transfusion.
What?
After that, continue monitoring closely.
Okay. What about hemolytic anemia? Uh, Autoimmune hemolytic anemia. Blood transfusion is need.
In autoimmune hemolytic anemia, transfusion is generally used very cautiously. You only give it if the anemia is really severe or if there are life threatening symptoms, because the immune system can react against the new red cells. So you try steroids first, and transfusion is really reserved for critical cases.
For critical care, I will do transfusion. At last blood transfusion. Cross matching. If I did not found cross matching.
Exactly. If you're giving a transfusion, especially in hereditary spherocytosis, you need to ensure proper cross matching beforehand. If you can't get a full cross match, you must proceed very cautiously, ideally with compatible blood and close monitoring, since these kids are at risk for alloimmunization.
Okay. What about the complication of hemolytic anemia?
Yes, absolutely. Complications of hemolytic anemia can include severe anemia, which may lead to fatigue, heart failure, or shock. Chronic hemolysis can cause gallstones. There's also the risk of iron overload if they need frequent transfusions. And in severe cases, you can get acute kidney injury, especially if there's a lot of hemoglobinuria. So close monitoring is really important.
Mhm. So, in microangiopathic anemia, I will do blood film. I will find schistocyte. Yes.
Yes, exactly. In microangiopathic hemolytic anemia, the blood film will show schistocytes, those fragmented red cells. You'll also often see a low platelet count and evidence of organ involvement, like acute kidney injury. So that pattern helps you pinpoint it.
Okay. While in immune mediated, I will find spherocyte and positive direct test.
Exactly. In autoimmune hemolytic anemia, you'll see spherocytes on the blood film, and the direct Coombs test will be positive. So the combination of spherocytes and a positive Coombs is really the hallmark. In contrast, it's the other patterns like schistocytes point toward a microangiopathic process.
Okay. Now, could you give all the subjects in briefly؟ ممكن تلخصي الموضوع في صفحة واحدة.
طبعا سأعطيك ملخصا سريعا. طفل في عمر 5 سنوات جاء بشحوب مفاجئ وصفراء. أهم التشخيصات التفريقية هي أولا فقر الدم الانحلالي بسبب نقص إنزيم G6PD، ثانيا فقر الدم الانحلالي المناعي، ثالثا خلل الكريات الوراثي، رابعا التهاب الكبد الفيروسي، وخامسا الملاريا. الفحوصات الأساسية تشمل CBC، تعداد الشبكات، مسحة الدم، البيليروبين، LDH، هابتوجلوبين، اختبار كومبس، وظائف الكبد، وتحليل البول. بعد ذلك بناء على النتائج تحدد السبب وتعطي العلاج المناسب.
Okay, could you speak in English?
Of course, here's the summary in English. A 5-year-old child presents with sudden pallor and jaundice. The main differentials include first, G6PD deficiency, second, autoimmune hemolytic anemia, third, hereditary spherocytosis, fourth, viral hepatitis, and fifth, malaria. Key tests include CBC, reticulocyte count, peripheral smear, total and direct bilirubin, LDH, haptoglobin, Coombs test, liver function test, and urinalysis. Once you have the results, you pinpoint the cause and apply the appropriate treatment.
Thank you.
You're very welcome. If anything else comes up or you need to review another case, just let me know. I'm happy to help.
Okay.